Episode 19, Shoulder Pain in a Young Pitcher. Welcome to Sports Medicine Case Studies, where I review published case studies in sports medicine. Okay, patient is a 15-year-old right-hand dominant male pitcher. He presented to a physical therapist with 1 week history of acute right shoulder pain. His pain occurred specifically during the acceleration phase of throwing. There was no other past medical history. On examination, his right shoulder had 140 degrees of external rotation, but only 5 degrees of internal rotation. The contralateral side demonstrated a left shoulder with 90 degrees of external rotation, 70 degrees of internal rotation. His horizontal adduction on the right was also 15 degrees less than on the left. The patient also had focal pain over the proximal humerus, particularly the lateral aspect. Additional provocative tests included the belly press and the liftoff test. The physical therapist initiated treatment for the acute symptoms, including soft tissue mobilization modalities, rotator cuff strengthening, and scapular stabilization exercises. Additionally, the therapist made a concurrent referral for imaging. So with that as the case, the differential I came up with and what the therapist initially described was number 1, subscapularis tendonitis. Number 2, based on the history, little league shoulder or humeral epiphysiolysis, a shoulder strain, or potential labral injury. I want to recognize the authors. The case report from Zipser et al., published in the Journal of Orthopaedic and Sports Physical Therapy. I'm Scott Hall, a primary care sports medicine physician, and I'm studying for my sports medicine certification exam in 2026. I hope you'll join me on the journey. This podcast is for educational purposes only. Okay. On return, the patient presented with plain radiographs, and these radiographs revealed lateral physeal widening with separation of the epiphysis from the diaphysis. An MRI was also obtained, and it confirmed widening of the lateral physis with adjacent edema in the metaphysis. The original plan included a structured return to throwing program. But once little league shoulder was identified, treatment shifted to complete cessation of throwing for 3 months. Once those 3 months had elapsed, the patient was gradually progressed back into his athletic activity. So a couple of key takeaways from this case, and I picked this one out because it's characteristic of the diagnosis of little league shoulder or proximal humeral epiphysiolysis. It is an overuse injury of the proximal humeral growth plate that occurs predominantly in young baseball pitchers between the ages of 11 to 16 years old, with a peak incidence of 13 years. The condition results from repetitive rotational stress during throwing, particularly during the late cocking phase when the shoulder transitions from maximum external rotation to forced internal rotation. This generates substantial external rotation torque that creates a shear stress across the proximal humeral physes. Patients typically present with progressive worsening, diffuse proximal shoulder pain during throwing that resolves with rest. They may also report decreased pitching velocity or accuracy. Physical exam reveals tenderness over the lateral aspect of the proximal humerus in approximately 70% of cases, and pain-limited deficits of shoulder range of motion are common. The diagnosis is confirmed with bilateral AP shoulder radiographs with the arm in external rotation, which demonstrate widening of the proximal humeral physes compared to the contralateral side. An MRI can be obtained if radiographs are negative, but clinical suspicion remains high. Management consists of complete rest from throwing for 3 to 4 months while maintaining other activities, followed by physical therapy and a gradual return to throw protocol. The prognosis is excellent, with one study demonstrating 91% of patients returning to asymptomatic play. However, recurrence occurs in approximately 7% of cases, with higher rates in those athletes with glenohumeral internal rotation deficits. Players with a history of little league shoulder demonstrate increased humeral retroversion and higher rates of subsequent shoulder and elbow injuries. One last point I want to make: patient and family education. This is always the part that I tend to have the most anxiety about, because I know that it can lead to some difficult discussions. But prevention strategies include adherence to pitch count guidelines and discussing the types of throws athletes are making, and the need for rest from throwing throwing activities, which is often in conflict with recommendations from coaches. Okay, couple of questions. Number one, a 13-year-old right-hand dominant male baseball pitcher presents with a 6-week history of progressive right shoulder pain during throwing. He reports decreased pitching velocity and accuracy. On examination, there's tenderness of the lateral aspect of the proximal humerus. Range of motion is limited by pain. Which of the following is the most appropriate initial imaging study? A, an MRI of the right shoulder. B, an ultrasound of the right shoulder. C, bilateral AP shoulder radiographs with the arm in external rotation. D, CT scan of the right shoulder. And E, a single AP radiograph of the right shoulder with the arm in internal rotation. Correct answer is C. The clinical presentation of this case is classic for Little League shoulder. The initial imaging study of choice is bilateral AP shoulder radiographs with the arm in external rotation, which allows a comparison of the proximal humeral physes between the throwing and non-throwing arms. The classic finding is widening of the proximal humeral physes on the affected side. An MRI is reserved for cases with negative radiographs but high clinical suspicion, and a single radiograph of the affected side would not allow for comparison to detect subtle physeal widening. Okay, question 2. During the pitching motion, which phase generates the greatest rotational stress on the proximal humeral physes, predisposing to Little League shoulder? A, the wind-up phase. B, early cocking phase. C, late cocking phase. D, acceleration phase. And E, the follow-through phase. The correct answer is C. Biomechanical studies have demonstrated that external rotation torque about the long axis of the humerus reaches a peak just before maximum shoulder external rotation, which occurs during the late cocking phase. This high torque creates shear stress across the weak proximal humeral epiphyseal cartilage, leading to either humeral retrotorsion or proximal humeral epiphyseolysis over time. While the acceleration phase generates high forces, the rotational stress on the physis is greatest during the late cocking phase. Question 3. A 14-year-old baseball pitcher is diagnosed with Little League shoulder. Which of the following physical exam findings is most strongly associated with an increased risk of recurrence after treatment? A, tenderness over the lateral proximal humerus. B, positive apprehension test. C, glenohumeral internal rotation deficit. D, scapular dyskinesis. E, weakness with external rotation. Correct answer is C. In the largest case series of Little League shoulder, 30% of patients had glenohumeral internal rotation deficit. The odds of recurrence in patients with these rotational deficits were 3.6 times greater than those without. All patients with internal rotation deficits receive physical therapy as part of their treatment. While tenderness of the lateral proximal humerus is a common finding, it is not associated with an increased recurrence risk, according to that case study. Question 4. Which of the following is the recommended duration of complete rest from throwing before initiating a return to throw protocol in a patient with Little League shoulder? A, 2 weeks. B, 4 to 6 weeks. C, 3 to 4 months. D, 6 to 9 months. Correct answer, C. The evidence-based management of Little League shoulder includes complete rest from throwing for 3 to 4 months while maintaining other activities. This is followed by physical therapy and a gradual return to throw protocol. In the largest case series, the average time to full resolution of symptoms was 2.6 months, while the average time to return to competition was 4.2 months. Premature return to throwing before adequate physeal healing increases the risk of recurrence. Okay, question 5. A 12-year-old male baseball pitcher presents with shoulder pain during throwing. Radiographs reveal widening of the proximal humeral physis consistent with Little League shoulder. Which of the following statements is correct regarding long-term outcomes? A, surgical fixation is required in most cases to prevent growth arrest. B, athletes who have had Little League shoulder have similar rates of future shoulder and elbow injuries compared to unaffected athletes. C, athletes with a history of Little League shoulder demonstrate increased humeral retroversion and higher rates of subsequent shoulder and elbow injuries. D, recurrence rates exceed 50% despite appropriate treatment. And E, most patients are unable to return to competitive baseball. Correct answer is C. A cohort study comparing high school baseball players with a history of Little League shoulder to controls found that players with prior Little League shoulder had significantly increased humeral retroversion on the dominant side and substantially higher rates of subsequent shoulder pain and elbow pain. While acute outcomes are excellent, as I mentioned before, about 91% of athletes were able to return to asymptomatic play. These athletes appear to be at increased risk for future upper extremity injuries. Surgery is not indicated and treatment is conservative with rest followed by a gradual return to play protocol. Final question. According to current prevention guidelines, which of the following recommendations is most appropriate for preventing Little League shoulder and other throwing injuries in youth baseball pitchers? A. Pitchers should throw year-round to maintain arm conditioning. B. Annual rest from overhead throwing should be at least 4 months, with 2 months being continuous. C. Pitch counts are only necessary for pitchers older than 14 years old. D. Curveballs and sliders should be introduced by age 10 to develop proper mechanics. E. Playing for multiple teams simultaneously reduces injury risk by varying throwing demands. Correct answer is B. Major League Baseball pitch smart guidelines and other prevention recommendations emphasize that in an athlete's annual training cycle, rest from overhead throwing should be for at least 4 months, with 2 months being continuous. Year-round participation without rest is associated with higher injury rates. Playing for multiple teams has been identified as an independent risk factor for throwing arm injuries. Pitch counts are recommended for all youth pitchers, and specifically pitches such as curveballs and sliders may contribute to injury risk when introduced at a young age. Thank you. See you next time.